let's have a look on our Shield Connect page. This is our Shield Connect page. It is basically a knowledge sharing platform of Shield Healthcare, and here you can find different blogs written by many eminent doctors in various topics in recent times. And these are the past webinars or medical sessions already we have conducted in our platform for last 2 years. And these are the different section of our Shield Connect page. Here you can find different sections like awareness kind of things, so that is PCOS awareness, menopause, GDM, or COVID-19 related topics, and thyroid awareness also. So as it's a very important in terms of our subject area, I request all the participants, please have a look on this website. And the most important thing is our key opinion leaders. So more than 500 doctors are presently supporting us this knowledge sharing initiative of Shield Healthcare across India. And now it's time to start the session with Madam, and it's my honor to introduce Madam. Madam is the Assistant Professor of Obstetrics and Gynecology, Jorhat Medical College and Hospital, and she is the Deputy Superintendent of Jorhat Medical College, and Madam is the Secretary, Jorhat Obstetrics and Gynecology Society. She is the Joint Secretary, Doctors Club, Jorhat, and faculty of MCI Regional Center for Faculty Development, Jorhat Medical College, Jorhat, Assam. And in terms of this field of area of interest, Madam has a keen interest on this endoscopy, infertility, medical education. So in this short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you, Madam, and over to you, ma'am. Madam, you are in mute.
Thank you, Sil, for giving me this platform. Now I would like to start my session. So today I'll be talking on UTI management in female. So before going to the proper management, I would like to throw some light on what is urinary tract infection. It is when we say urinary tract infection, it occurs whenever there is infection, invasion of bacteria into the urinary tract, and that multiplies and causes some symptoms. It is the second most common infection in our body. Women are especially prone to this urinary tract infection. 1 in every woman will develop UTI during their lifetime. UTIs are not that common in men, but they are more serious when they occurs in male.
Sorry for the interruption, Madam. Can you please full screen it, Madam?
Okay, full screen.
Yeah, means.
It is in like full screen only in my.
We can see the first slide itself. Are you there in the first slide?
No, I'm in the second slide now.
That is why the problem. Ma'am, can you please unshare your screen and share?
Yeah, again I am sharing. Okay. Is it okay now?
Yes, ma'am. And in the drop, means in the lower panel, you can see one slideshow button. So
yeah,
from
slides.
there you can. Yeah, there also. Yes, ma'am.
Can you see my slides now? Yes.
Actually, I guess that one is old. So, ma'am, can you please see this lower panel? You can see 74%. And the left button of the 74% is the full screen button. So can you please press that?
Keep it on a slideshow mode, ma'am. Slideshow mode.
Yes, madam actually did that one, but it is not showing here. So that is the problem.
It is not shown here. Deepak, can you share from your end that slides? I have forwarded you.
Deepak is there. Deepak, do you have the slides with you?
Sir, have, but I am not downloading in my laptop. So I am having from mobile.
Okay. I'll just try it again. Okay.
Yeah, ma'am, just do one thing. You please share the screen, and in the lower part, you can see that 74% or some zoom area is there in the lower right panel, right corner of this of your computer. So after opening this PowerPoint only, you can able to see that one. So
Okay.
on, you please share the screen. Yeah, you have shared the screen,
Yeah.
and in the yes, now it is fine, ma'am.
Now it is okay, madam.
It is okay, madam. It is
Okay.
coming fine, ma'am.
You
Sure.
can see my first slide, or
Yes.
second slide.
It is what is
What is urinary tract
urinary
infections,
tract
right?
Okay. Okay.
Sure. You can proceed, ma'am. Sorry for the interruption.
Just a minute. It's not moving only slides. Yeah. You can see the change of the slides.
Yes, ma'am. Yes, ma'am. We can see.
Okay. Okay.
Everything is fine, madam.
Okay. So next, coming to the epidemiology of this urinary tract infection. So if we go through the incidence, we have adult women have 6 to 10% per year. It is 4 to 10% in pregnant ladies, and it is 1 to 10% in normal patient who have been put on catheter, and those who are debilitated, it's very high. The incidence is very high, that is 10 to 15%. And when we see the female to male ratio, it's 10:1. That means we have a very high incidence in female. So factors that results in a compromised normal host defense in bacterial colonization, that is an important step in the pathogenesis of urinary tract infection. So we have some risk factors which prone us for urinary tract infection. These are iatrogenic drugs, like indwelling catheter, as I already mentioned, that when a patient is on catheter, it provides the ascending route for the perineal bacteria to enter the bladder. So that increases the risk of urinary tract infection. Then if somebody is using antibiotic more often, that will kill the normal bacteria, and that will allow the uropathogens to colonize in the urinary tract. Then use of spermicides. That spermicide causes irritation, and that causes breach in the mucosal continuity that enhances the like E. coli to colonize there on that eroded part. Then behavioral, some people have some voiding dysfunctions, like they have more increased post-voidal residual volume, or you can say, on the other hand, what females used to do if they do not have a suitable place to micturate, then what they do, they keep the urine for a longer period, and that causes an increased volume of urine in the bladder. That causes allows more time for the bacteria to multiply and proliferate. So that causes that makes them prone to urinary tract infection. Then frequent or recent sexual intercourse may introduce bacteria into the urinary tract. If someone had intercourse, they should actually go and micturate or urinate, so that whatever bacteria has entered, that can be flushed out. Then anatomical and physiological. There are certain anatomical problems like vesico-urethral reflex, which allows more time for the bacteria to grow. There is retrograde flow, urine flows backwards, so the bacteria can ascend up to the kidney. Then female sex. Females have a short urethra, unlike men. So what happens, this E. coli, which is in and around the anus, that can easily ascend up. Then pregnancy results in progesterone mediated smooth muscle relaxation to the bladder and ureter, and that compresses the ureter by the uterus. Both results in urinary retention and increased bacterial growth. Then there can be some genetic issues, like familial tendency, susceptibility to uroepithelial cells, and vaginal mucosal properties. So these are certain genetic factors which can make one person prone to urinary tract infection. If we see the etiology, most common cause is E. coli, which is the normal bacteria that lies in and around the anus, and this is the fecal flora that colonizes in the periurethral area, and that easily ascends up. And other bacteria can be Klebsiella, Proteus, Enterobacter, Staphylococcus, Group B, beta hemolytic Streptococcus, then others. but these incidents are very less, but whenever we do a culture, most of the time we get E. coli. So pathogenesis, how it becomes, first is colonization. Colonization means there is pathogen colonizes in the peripheral area. Then fimbrias allow the epithelial cell attachment and penetration. That following this penetration, bacteria continue to replicate and may sometimes form this biofilm. So in the urinary bladder, there will be penetration. Then from the urinary bladder, if there are ample of bacteria, then it can ascend up in the ureter. If it is ascending up, there can be pyelonephritis and there can be acute injury to the kidney. So there are certain symptoms called genitourinary syndrome of menopause or genitourinary syndrome. This is in 2014. This new term has been coined to some symptoms which are associated with menopause. This is defined as collection of symptoms and signs caused by hypoestrogenic changes to the labia majora, minora, clitoris, vestibule, introitus, vagina, urethra, bladder that occur in menopausal women. So basically, there are three types of symptoms: genital symptoms, sexual symptoms, and urinary symptoms. In the genital symptom, we get dryness, burning, and irritation. Sexual symptoms, there can be lack of lubrication, discomfort. Urinary symptoms, urinary urgency, recurrent urinary tract infection, this can occur. Then why there is this more infection in menopause? Because estrogens are low. That causes decrease in the normal lactobacillus of the vagina. And this normal lactobacillus of the vagina, which maintains the pH of the vagina. So because of the decreased level of lactobacilli, there will be increased vaginal pH. This increased vaginal pH leads to colonization of the vaginal and enterobacteriaceae from the rectum. So menopausal women are more prone for this sort of infection. And another factor is that vaginal atrophy. When we see estrogenic effect, we get healthy vagina that is full of thick and moist vagina. But when there are less of estrogen, we get atrophied, thin, dry vagina, which is very much prone to injury, or because of dryness, you can say. So that leads to increased colonization of the bacteria. So how one present with urinary tract infection? Mostly they present with pain, burning, micturition, fever, frequent urge to urinate, low backache, and fatigue. So basically these symptoms are because of two things. One is because of emptying symptoms or some storage symptoms, if we categorize it in broad category. So emptying symptom means there is weak in the urinary system, so there can be hesitancy, difficulty starting of the urinary stream, resulting in delay between initiation of urination by relaxation of the urethral sphincter and when urine stream actually begins. And next is intermittency, interruption of the urinary stream while voiding. Some people feel it very distressing that they have to go to the toilet repeatedly. Then post-void dribbling, there can be wetness after voiding. So this urine loss after completion of voiding can be a distressing symptom again. Then urinary retention or incomplete emptying, inability to empty urine from the bladder, which can be caused of atonic bladder. Then dysuria, there can be severe pain or difficulty during urination. Then there can be some, the symptoms can be urinary frequency and abnormally high, like they feel micturating. So urgency, a sudden, strong and intense desire, they cannot wait for the proper place to void. Incontinence, there can be involuntary or unwanted loss of or leakage of urine because of some storage problem. Then nocturnal, they have to wake up every 2 to 3 hours to urinate. Then nocturnal enuresis, they complain of loss of urine during sleep. In children, it is called bedwetting. It sometimes happens. How to proceed for management? First of all, we need to go for a blood analysis. We need to see her complete blood count, then electrolytes, blood urea, serum creatinine, and one more important is routine blood sugar level. Then urinary studies, we routinely go for routine RE urine where we can see pus cells, and we can go for urine culture and sensitivity test, which we usually do for pregnant ladies at the booking visit to us, that is the first visit to us, and again at 16 weeks. So if she has some symptom, then it can be symptomatic or it can be asymptomatic. We are getting the bacteria, but there is no symptom. So asymptomatic bacteria is very common in pregnant ladies. So how to collect this urine? With one hand, they will spread the labia, because if there is contamination of the container, there we can have a false impression of this urinary positivity in the urinary culture. So they have to wash their hand, then they have to separate the labia, then with one hand they will hold the container, and we will catch the midstream of the urine, not the first one, but the middle part of the voided urine. Then they will lock the urinary container and they will seal it, and they will send for the testing. Now, there are certain guidelines in pregnancy. If it is asymptomatic, then we have some guideline. If symptomatic, we have guidelines. Then acute cystitis, if we have bladder involvement, then acute pyelonephritis if there is involvement of the kidney. Asymptomatic bacteria in pregnancy, that is, if there are, we need to go for a quantitative estimation of the bacteria. That is, if it is present, for how much colonies are there. So if it is more than 1 lakh colony forming unit per ml or of one or more uropathogens in 2 consecutive midstream specimen or 1 catheterized urine specimen in the absence of symptoms attributes to urinary tract infection. If it is more than 1 lakh, we will call her to be suffering from urinary tract infection. And this, usually we get 2.5 to 11% of the pregnant ladies, we get this asymptomatic bacteria. In non-pregnant, just around 3 to 8%. So for screening, all pregnant women must be screened for this asymptomatic bacteria on their first prenatal visit, then at 16 weeks of age of gestation. So if asymptomatic, antibiotic treatment can be initiated upon the diagnosis of asymptomatic bacteria, because if we do not treat it, then it will ascend up and it will injure the kidney. So nitrofurantoin, if it is near term, we don't prefer giving this. Otherwise, we can go for it, co-amoxiclav, cephalosporin, cotrimazole, depending on the sensitivity. And it should be given for 7 days course, that is recommended. Short course of nitrofurantoin is not that much effective. Then symptomatic, if she has symptom, then standard, we do whatever way we have already described that urine culture we have to go for, then confirm the presence of bacteria, then we will treat. Then this FDA has a recommendation, category B drug, we have nitrofurantoin, amoxiclav, and cephalosporins, but that will depend on the sensitivity report, of course. Whatever bacteria antibiotic they will be written in the culture report, sensitivity report, we will try with that antibiotic first. Acute cystitis in pregnancy is characterized by urinary frequency, urgency, dysuria, bacteria without fever, costovertebral angle tenderness. So typically in pregnancy, we don't get the typical symptoms of urinary tract infection. Rather, we get backache. That is the commonest symptom what we find in clinical practice, that they have either backache or they will have low abdominal pain that is also very vague, but they are not having any burning, micturition, dysuria, that sort of symptoms we usually don't get. So if they have that much, or there can be gross hematuria, that is also a rare manifestation. But yes, if they have this, then we have to go for culture sensitivity, then we have to give that proper antibiotic, whichever is suitable for her. Acute pyelonephritis, yes, it is not very common in early pregnancy, but in late pregnancy, 2nd trimester and 3rd trimester, this can happen. And this actually is a very it can be called as a silent killer, because we don't even know that her kidneys are going to a bad track, because after delivery, many of the time we get acute tubular necrosis or acute kidney failure cases. Only after delivery we could diagnose because of the silent nature of the disease. So we have to screen, and we need to go for proper diagnosis of this acute pyelonephritis. In non-pregnant women, consider empirical treatment with an antibiotic for otherwise healthy women is at less than 65 years, presenting with severe or more than 3 symptoms of urinary tract infection. We have to explore alternative diagnosis, consider pelvic examination for women, because vaginal infection is very much common in women who are, like, it is common in pregnancy also, but it is not that much like this, more common in non-pregnant because of many factors. So if she is having a urinary tract infection, it is our duty that we go for a high vaginal swab culture too, if it is not, like, if it is coming up recurrently. So we have to exclude a vaginal infection along with urinary tract infection. And one more thing is that we have to screen the partner also. If the partner is positive for urine culture, then they have also, like, we have to treat him also along with her, otherwise the symptom will persist. Use of dipstick to guide treatment decision in otherwise healthy women, it can be done. We can just see the naked this urine sample. If it is dirty, it is not clear, then we can have a presumptive diagnosis of infection in it. If they have already 2-3 symptoms of urinary tract infection, then we can start our antibiotic, blanket antibiotic we can just start, and then we can have the specific antibiotic on the basis of urine culture report. Do not treat non-pregnant women with asymptomatic bacteria with an antibiotic. Actually, if they have low or lower urinary tract infection, if you think it is not cystitis, it is not pyelonephritis, then we should, like, you can wait for some time. We can give alkalizer or some adjuvant therapy, so that we can wait for the urine culture report, so that she is not been given too many antibiotics. So we can wait for 3 days if we are sure that it is lower urinary tract infection. So if it is lower urinary tract infection, we can give 3 days course of this nitrofurantoin or trimethoprim for non-pregnant women. Care should be taken when prescribing nitrofurantoin in elderly because it has toxicity. Then take urine culture to guide change of antibiotic for patients who do not respond to this antibiotic, the first line of antibiotic. Then during antibiotic treatment, we give antibiotic to all symptomatic women. Then we take this urine for culture sensitivity. If it is, if they are symptomatic, we can continue for 7 days course. And given the risk of symptomatic bacteria in pregnancy, urine culture should be repeated after 7 days. If we are treating a symptomatic bacteria in a pregnant lady, then we should repeat it 1 week after urine culture. If urine is sterile, then it's okay. If it is not sterile, then probably we need to have to continue the antibiotic for another 1 week. So which antibiotic to select, that depends on actually which group of people she is in, because if she is pregnant, obviously there are some antibiotics which are contraindicated, some are not. If she is elderly, that way we can select the antibiotic, and otherwise if urine culture, it will be the prime thing that will guide us which antibiotic to be selected. Repeated urinary tract infection. Repeat urine analysis and consider urine culture and sensitivity. So here also we have to be very much careful that from where she is getting the infection. If she is having recurrent infection, why she is getting a recurrent infection. So imaging modalities like ultrasound or MRI can guide us if there is a stone in the urinary tract which is causing this recurrent UTI, or if her partner is positive for urinary culture, if she has some problem in the vagina which is causing the urinary tract infection again and again. So that has to be there, and proper guide like antibiotic we have to pick up, and we have to give in the required doses and required duration. In menopausal women, as I have already said, that because of the dryness this occurs, so we need to give vaginal moisturizers, estrogens, vaginal estrogen we can give, and oral vitamin D has also some role in reducing the urinary tract infection. There are certain non-antibiotic therapy like cranberries. This contain a compound of pro-erythrocardin, which can reduce the bacteria by preventing colonization of E. coli in the vaginal mucosa. They also help in reducing the urine pH and thereby decreasing the UTI symptoms. Ascorbic acid may help in acidifying the urine and thus prevent urinary tract infection. D-mannose is an antagonist of the bacteria adhesion. This I will come into it. It prevents urinary tract infection by stopping the bacterial adhesion to the uroepithelial cells through a competitive inhibition mechanism. Some studies shown that D-mannose is a good alternative for the treatment and prevention of uropathogenic E. coli. However, most studies are needed before prescribing D-mannose for postmenopausal women in recurrent UTI. So now recommendations are coming up, but no recommendation for or against have been made for ascorbic acid, cranberry juice, D-mannose yet, but we need more research on this field. So newer approach in the treatment, probiotics. So we know that deficiency of this lactobacillus species in the vaginal epithelium postmenopausal leads to recurrent UTI. So use of both oral or intravaginal lactobacillus can increase the vaginal colonization of lactobacillus, which is the normal common cell, and that will prevent pathogenic bacteria to grow in the urinary tract or vagina. Most studies are required to establish this again. Immune therapy with further evidence on urobioma and uropathogens in recurrent UTI, immune therapy has been gaining significance. We are getting few products in the market, but yes, we need more studies on this also. E. coli lyophilized lysate is an active immune stimulant helped in reduction of inflammation in bladder. So this technique may be a viable alternative to prevent cystitis, but more human studies are required. This will work as a vaccine for urinary tract infection if it, in case it comes to the market in a bigger way. Persistent acute pyelonephritis infection, generally IV hydration, antimicrobial therapy are followed by stepwise deviation of approximately 1 degree Fahrenheit per day. With persistent spiking fever, lack of clinical improvement in 48 to 72 hours, urinary tract obstruction or other complication, we have to consider the cause of recurrent infection, and we have to treat the cause so that we can prevent this recurrent infection. It can be because of diabetes also. So we have to know the cause so that we can treat it completely. So there can be urinary obstruction, there can be abnormal ureteric dilatation, nephrolithiasis, intrarenal perinephric abscess. This we have to handle. So persistent infection, we have to go for thorough imaging, then obstruction relief if we have, in case we have stones, then percutaneous nephrostomy, surgical removal of stones. So these have to be done before, like if there is recurrent infections are going on. So there is one name, that is the biofilm. Why there is some culture, urine culture, we don't see any bacteria, or the culture is sterile, but like culture is sterile, but she has symptoms, active symptoms of urinary tract infection. This happens, we get reports like that. So answer lies in the intracellular bacterial colony formation. The bacteria are inside a phlegm, so that it is not seen in the culture, or there is no bacteria on culture, but it is causing symptoms. So what is it? This uropathogenic E. coli that invades urothelial cells lining in the urinary bladder, and that forms intracellular bacterial communities or biofilm. It is inside the urinary bladder, cells of the urinary bladder. So the infection remains undetected in normal urine culture and causes recurrence. So this culture negative infection persists, present as unexplained dysuria, urgency, and they are termed as interstitial cystitis or bladder infection. So to prevent these recurrent infections, we need continued antibiotic prophylaxis till the end of pregnancy. In case she is pregnant, nitrofurantoin is the safer thing, but yes, we have to see the culture test also, that whether it is sensitive or not. Then intake of 150 to 700 ml of cranberry juice or concentrated equivalent is effective in preventing recurrent urinary tract infection. Maintain local hygiene, drinking 3 to 4 liters of water, women who are sexually active can be advised to postcoital voiding. So current treatment options that we have, first, to relieve burning micturition, we can give alkalizer, which will neutralize the pH and this burning will go. Then to relieve the pain and spasm, we have antispasmodic and painkillers, then cranberry to flush out the bacteria, then antibiotics to eradicate the bacteria. So how does ursolic acid helps? It's a powerful anti-inflammatory drug and analgesic, inhibits the pro-inflammatory cytokines, tumor necrotic factor and prostaglandins, anti-inflammatory effect comparatively to idometasis. Then powerful antioxidant, it prevents tissue damage and inflammation due to the oxidative stress. Then potassium, this is one of the most commonly used drug in urinary tract infection. This potassium magnesium citrate produces high concentration of bicarbonates in the urine that neutralizes the acidic urine of infected urine, and that promptly relieves the burning micturition in urinary tract infection. D-mannose. Actually, D-mannose, we can see this D-mannose. D-mannose have a similar structure to binding site of urothelial glycoprotein. These urothelial glycoproteins are like this, and this D-mannose, if it is sufficiently there in the circulation, then this can bind with the phlegm H adhesin and prevent the bacteria from binding to the urothelial glycoprotein. Instead of binding to this uroplakin receptors, it will bind to this D-mannose, and this bacteria will be flushed in the urine. If it can work, D-mannose, if it is in required sufficient concentration, then only it can bind to this phlegm H. Otherwise, some will bind to this and cause urinary tract infection. So effect of this cranberry. So it inhibits the actually these are very much in study level, but taken together, this data suggests that cranberry may suppress elements of signal transduction pathway that lead to inflammatory response in response to bacterial lipoproteins. So how to sum up the urinary tract management? So how to prevent, or prevention of urinary tract is very important, because if it happens recurrently, that it has an impact on the kidney too. So maintain hygiene, wash hands before using toilet, wipe back front and the back after urinating or defecating, clean urethral matters first while bathing, wash clothes to clean the perineum, use liquid soap instead of bars to prevent colonization of the bacteria in the bar. Urinate before and after intercourse, wear comfortable and clean clothing, preferably the fabric, then consume a healthy diet, then stay hydrated. Drinking 3 to 4 liters per day is a very good habit to prevent urinary tract infection. Avoid caffeine. That caffeine irritates the urinary bladder, and if you are taking more of coffee or caffeine, then it can cause, it can predispose you for urinary tract infection. So we have a product that is have this UTI flush, which works in 3 ways: pain, burning micturition, and recurrence. This has ursodeoxycholic acid, is potassium magnesium citrate and cranberry extracts. So as I have already told, that urosolic acid, it causes powerful anti-inflammatory analgesic effect. It has anti-inflammatory effect that is comparable to the NSAIDs, powerful NSAIDs. Then potassium citrate normalizes the pH that acidified urine into infected urinary tract. So activate ingredients of cranberry that exerts anti-adherent property, so it is flushed out, and D-mannose is also there in UTI flush. Thank you for your patient hearing.
Thank you very much, madam, for this nice presentation, and as you covered almost all the things related to this important problem. So just give me 1 minute time, ma'am, to check whether any questions in the chat box. So, ma'am, the first question is, ma'am, how do you manage this UTI in case of pregnancy? I mean, Is there any difference in the treatment strategy in case of the early pregnancy and in case of the late stage pregnancy?
Yes, in early pregnancy, we don't prefer giving any antibiotic other than cefixime group. So if somebody is having urinary tract infection, if she is having a, like we have a urine culture report that is suggesting for some antibiotic, which is like contraindicated for first trimester of pregnancy, then it is very difficult for us to decide which one to start and how to keep her symptom free. Because that time we ask her to drink plenty of water and give cefixime antibiotic. Otherwise, like alkalizer we can give, but antibiotic, yes, for antibiotics we have to be very much careful. We cannot give up to 12 weeks. We actually prefer not giving antibiotic. So even if we require, we can give paracetamol if she is having symptoms, but yes, only symptomatic. We will not be focusing on treating that time, treating it
Yes.
treating is actually treating it completely, because we have to probably wait for second trimester to give more accurate antibiotic if it is there in the culture report.
Yeah, thank you very much, ma'am. Another question is, ma'am, in case of this cranberry extract or rosemary extract, so what is your practical experience? Does it can it be given alone, or it can be used with antibiotics so to get maximum results? So what is your practical observation on that?
See, cranberry extracts are not the bactericidal effect. It don't have bactericidal effect. It will give you symptomatic relief, and it will prevent that bacteria to adhere, or it will have flushing effect. So basically cranberries are given along with antibiotic, and immediately the patient get relief of this, because there is a like you take with water, you are taking juice, so you are taking a lot of water along with it. So, or if you are taking a sachet, you are putting in water, and you are putting a lot of water in it. So basically it's a combination therapy. It's an adjuvant therapy, not the mainstay therapy. So you cannot replace antibiotic with cranberry, but yes, it has a very good result with antibiotics. Especially the symptoms subside within like maybe after 1 to days, there will be relief of the symptoms.
Okay, madam. Thank you very much, madam. So thank you very much, madam. I could not find any other question right now. Okay. Thank you once again for your valuable time in our platform also, and for discussing a nice topic and a very important topic that is affecting almost all the female population in their lifetime. So thank you very much for this nice presentation once again, and have a good day, madam. And in future also, we will look forward for some valuable session with you, ma'am.
Thank you so much, doctor. And thank you so much all the delegates who attended.